My name is Heun. I'm a consultant psychiatrist and professor of psychiatry. Today I would like to talk about the treatment of obsessive-compulsive disorder in our series Mental Health Explained. And the treatment of OCD, obsessive-compulsive disorder, is usually with CBT. The approach usually is to prevent the response to an exposure. So it could be that people have to, walk upstairs in prime numbers or have to lock the doors, check the doors, cleaning, checking, and what you try is to convince the patient to or not to do the actions. Usually the actions are related with anxiety, and to prevent the anxiety, the compulsion is practiced. So people would be put in a situation where, or they are in a situation where they would like to do the actions such as cleaning hands, and they would prevent it to do that. And the hope and the assumption is that the anxiety would go away, and that they would then learn that the anxiety will go away eventually and that the action is not needed. So the compulsion will then wane off, if that works well. The cognitive part doesn't really work very well because usually most patients have thought through the absurdness of their actions. They know that it doesn't help them to wash their hands 100 times a day, but if they do it, it just shortly releases the anxiety, and that's why they do that. And the response prevention is to relearn it in a different way. There's also supportive psychotherapy, and sometimes it includes the family, and it can be psychoanalytical, and it's usually very time-consuming. Pharmacotherapy can be quite helpful. Usually the first line of treatment is SSRIs, such as fluoxetine, escitalopram, fluvoxamine, sertraline, or paroxetine. Usually one would try 1 or 2 SSRIs, and if they don't work, one would go to other medications such as clomipramine. Clomipramine has been assumed and has been effective in anxiety disorders, including OCD, and it was the first choice before SSRIs came on the market. Venlafaxine and other antidepressants can be tried. Sometimes it can be very helpful to add or just treat only with antipsychotics. Usually risperidone, haloperidol, pimoside are the first, but currently the second line or the second type of antipsychotics or secondary antipsychotics are used, such as olanzapine, quetiapine, aripiprazole, and paliperidone. I remember a patient who had lots of rituals and it took her several hours to eat. The food was usually cold and the mum would reheat it, and we started with a low dose of olanzapine, and in a couple of weeks the symptoms were gone. They came back after the medication was stopped by the GP, but again, after one restarted it, it was gone again for quite some time, and she is living a happy life without with her medication. In severe cases, there were recommendations of ECT if patients are suicidal and can't cope with their obsessions or compulsions, but that's usually quite unusual. When you see this as a psychiatrist today, usually people tell you the story that they had this treatment before and it was helpful. Psychotherapy surgery has been recommended. It is called a stereotactic cingulotomy, and they reported success. Dialectic behavior therapy is a different type of cognitive behavior therapy, but there are not really any case reports or publications showing the efficacy of that. Usually the course of the OCD is quite long-term. Sometimes people have tried to hide it, or they didn't understand it as a mental health disorder. And usually before we see patients in the outpatients clinic, they have several years or up to 10 years or even more of symptoms. Usually when you try with medication, you have a third who improve, another 50% or half of the cases show some improvement. Then they easily, as I said before, relapse when you stop the medication. People are suicidal and they are very often comorbid with depression. In general, the prognosis is not the greatest, depending on the previous duration of the disease and the involvement of the family sometimes. If there are bizarre compulsions or such as hoarding or symmetry, things can be worse. So it's very often the case if the medication work or the accompanying CBT has some tool or some lever to prevent the compulsions and do this when there is exposure. So the question is, can this be stopped? Sometimes when there are just mental, just obsessions and ruminations about things, delusional beliefs, then it can be very difficult. If people have a good family adjustment or being supported and have not a disease which is not too long, the outcome can be better. So if you have or you know someone who is suffering OCD, excessive ruminations or excessive compulsions, it's always worth to contact your GP and a psychiatrist who is involved with that. We had some recent publications and where we looked at the outcome, and sadly there is an increased 5-fold risk of suicide in patients with OCD. So this has also been to looked at, and usually to prevent suicide, it's to talk about suicide. Thanks for your attention. If you like this, please subscribe to our channel, and if you want to learn more, we have many more videos on mental health explained, and we also have videos of publications and lectures about mental health issues. Thanks for your interest and have a nice day.